for our eShadowing session. I hope you're all ready and excited to learn a lot from today's presentation. Today we have our presenter, Ursula Lang. She's a doctor specializing in dermatopathology, and she'll be sharing about her journey towards medicine and her specialty. Just as a reminder, towards the end of the session, we will be posting a Google link in the chat for you guys to take the assessment. You can pass with a minimum of 7 out of 10 to receive your credit for the session. And with that being said, Dr. Lang, whenever you're ready, you're welcome to start.
Okay, wonderful. I'm happy to be here. Thank you for inviting me. And yeah, let's get right into it. Let's see if I can. Okay. So what made me want to go into medicine? So both of my parents actually worked in a clinical lab in the hospital. So they're the ones who process samples. My mom was a microbiologist. My father was basically did blood bank and was a technician and worked with within the hospital to help out patients in that way. And because we grew up in a rural little town in Texas, and my mom worked 2 jobs, and she took me with her on the weekends, and I just was surrounded by it all the time. And really the lead of a clinical lab is a pathologist. And so I think maybe subconsciously growing up, I would constantly hear my parents talking about the pathologist said this or that. And I kind of knew that the hierarchy was the pathologist was the one making the decisions about diagnoses and really helped facilitate some of the things that happen for patients once they're trying to figure out what's wrong with them. And so at the same time, I got really involved in science projects growing up. I just found the creativity in science to be fascinating. And so putting those two together, I really decided that medicine and science together were the way that I wanted to contribute. And again, I think it was just the exposure early on that really had perhaps my parents been engineers, maybe I would have been an engineer, but in the end, we'll never know. And here I am, a physician and a scientist. So my background, I grew up in Texas in a small town. But then when my parents decided to move us up to Seattle, I think for me, that was really an opportunity to kind of expand some of the opportunities and resources I was able to be exposed to, and then decided to stay local. Went to University of Washington. I decided to major in biochemistry, kind of still going along this interest. My predominant interest at the time was science, but at the time I also had in the back of my mind that pre-med was going to be something I also pursued. And I did a dance minor just because I think with everything being so intensely science-based and rigorous. For me, having dance, and University of Washington has a very active dance program and arts program. So that was just one way that I found balance in undergrad, was to have both of those things. And I felt like that served me well. The other thing that I did in undergrad was apply to various scholarships and programs. So at every opportunity, I really utilized all the different, I went to the Office of Diversity quite often and always just asked, like, is there something I could be applying to? Are there opportunities available? And can I get involved in that way? And having grown up in kind of a lower middle class to middle class, and my parents were both immigrants to this country, and hustled 2 jobs all the time growing up, I was always kind of acutely aware that when I went out there looking for opportunities, I was going to look for ones that were going to sponsor the activity. Things that were going to actually provide me a stipend or pay for the activity that I was interested in doing. And so with that in mind, I really went out there and pursued looking for those actively. And as another little side note related to my family, my mom grew up in Peru, and she was one of 2. There's a nationwide search in Peru for a couple of high school grads who were interested in going to the US to study. And so through various tests and whatnot, she was chosen as one of them. And so I think, having also heard that story growing up, that she came to the United States on this full scholarship, and really that opened the doors to all the possibilities that could be out there. I always had that in the back of my mind, and so I think just kind of seeing those examples around me really helped me, and which is again another reason I want to share this with everyone here, because just being more active on that front really does open doors, and you can kind of find the opportunities that eventually down the line you can always go back to and talk about and speak and have you kind of stand out in sort of the big pool of pre-med students. So that was a couple of things in undergrad. One of the ones that stood out for me quite a bit was this undergrad international research program that I applied to. It's called Multidisciplinary International Research Training, or MERT, and I believe there's a few different there's several universities that have this program as part of their opportunities for undergrads. So when I applied to it, they matched me to Ecuador. So I actually spent the summer I believe it was between sophomore and junior year in Ecuador, studying health disparities, maternal fetal health disparities in Ecuador. So as part of that program, I learned a little bit more about statistics and went with a group of other undergrads and kind of had this beautiful bonding experience with them as a group. And we went out and kind of learned what it means to do research abroad, and what's involved in getting out into the communities, seeing what actual variables stand in the way between a mother getting access to healthcare in these more rural settings. So for me, that kind of was, again, just me exploring what area do I want to focus on. I knew I was very interested in research all along, and sort of where was I going to focus my research efforts? Was it going to be epidemiology, which actually when I applied to medical school, that was one of the things I had at the forefront of my mind, that I would do my PhD in epidemiology. And this is coming back to this experience in undergrad where I saw epidemiology as being one way to really study and figure out what are the things standing in the way between healthcare and people seeking healthcare. So to me, that was an impactful experience. And then right after medical school, and also getting advice from various mentors and faculty advisors, I knew that in order to continue pursuing down the research track, I would need to become involved in more research as a longitudinal experience. And so in undergrad, I did, have a couple of labs I would do small projects in. The MERT program stood out for me, but I also had, during the academic year, I had various labs that I would go in after my coursework, and I would go in and help out, and I would learn, and I would be paired up with a graduate student at the time, and I would just kind of learn some of the basic techniques of lab work. And so based on that, I was able to get accepted to the NIH Academy, which actually takes place at the NIH. And it was kind of a rigorous application process too. They interview you and you write essays and why is this important? And so this program really focused on wanting to expose young investigators to the importance of health disparities and research in these areas. And so this I just point out because if anyone is interested, there are application deadlines coming up in August of this year, and there's various programs that are available. So the NIH fellow, I think this has changed a little since when I did it, but they have various arms, and there's some differences between all of them. But this was, again, just my way of really exposing myself to more research before medical school, but also having something to speak about and to kind of during medical school. And what I ended up doing was the MSTP program, which is a combined MD and PhD. For those programs, really showing kind of a track record that I am all invested in research. I am invested in being involved in like advancing medicine through research, that's actually very important to me, that I took the extra time to take a year between my undergrad and medical school to do this program. And so from there, I still was on the fence actually about whether or not I wanted to do a straight MD and only, or an MD PhD. And I even considered a PhD on its own as well. So I applied to everything. I applied to all of the programs. And interestingly, I didn't really get as many medical school straight MD interview opportunities as I did the MD PhD opportunities. So, and I think it probably is due to the fact that I had on my CV already several experiences to show how my interest in research was something that was important to me. So, so I interviewed all over the country for the MD PhD program, which, if anybody isn't familiar with it, there are some medical schools who have MD PhD programs as two separate programs. So you would pay for medical school, and then the PhD portion, the graduate school portion, is paid for, and on top of it, you get a stipend for every year that you're in graduate school. Whereas the medical scientist training program, or MSTP program, this is sponsored. This is sponsored by grant money from the NIH to actually support the whole process. So the idea being that if your medical school and your graduate school training is completely paid for, then you have a little bit more liberty to have years after your residency to really go dive deeper into research without that financial burden. So I got into, I think it's maybe the next screen. Yeah, medical school. So I got into to what is now called Icahn School of Medicine at Mount Sinai. When I started, it was just Mount Sinai. But since then they changed the name. And again, the medical scientist training program is a combined MD and PhD program together. And the way that they like to do it is having the first 2 years of medical school first, and then you have your graduate school years, which for me, it was 5 years because I also had my first son during the graduate school years. And in the end, that because of the time commitment for having a son during graduate school, it was an extra year. I probably could have finished otherwise in 4 years. But then after the graduate school training and my PhD being over, I went back to medical school and finished out the clinical years, the third and fourth year. So that was my experience during medical school. I included, I believe, a slide next. Yeah. So Mount Sinai is on the Upper East Side of New York City. And for anyone who's not familiar, Upper East Side is really kind of Park Avenue. It's kind of the more well-off population of Manhattan lives in the Upper East Side. But right north of the Upper East Side is East Harlem, which is another name. It goes by Spanish Harlem because there is the population that lives there is heavily Puerto Rican, Dominican, and quite a few patients from Mount Sinai are Spanish speaking. So for me, Mount Sinai was a special experience because I really saw the full range of, like the most up-to-date techniques and surgeries and medicine. And also I volunteered at the free clinic through the it's a student-led free clinic that was set up at Mount Sinai to really meet some of the needs of the underserved within East Harlem. And so speaking Spanish myself, that was another thing that was really helpful to have that and kind of do both. And I really felt like New York City is very different from Seattle, and I had a great time exploring Manhattan with my friends there. So that was fun. So I wanted to just touch on graduate school. So the reason I have a liver here is because I ended up joining a lab that studied liver disease. And the head of the lab, my PI at the time, my principal investigator at the time, was actually the director of the liver disease center at Mount Sinai. So he's an MD without the PhD, but he was still able to go the research route, establish a lab for himself and see patients and also do research. And so one of the reasons I joined his lab is because I saw him as a good example of the ability to do both, to really maximize both sets of skills, being a physician and also being a scientist. And so throughout, I've always kind of looked for mentors who are doing it successfully and seeing what they're doing and trying to learn from them, but also get advice and sort of make my way in my own path. And so my project really focused on the mechanisms by which a healthy liver, the cells in a healthy liver, eventually can lead to carcinoma through various mechanisms. So a healthy liver after either infection with HCV or like alcohol or fatty liver, there's various ways that the liver can undergo fibrosis and cirrhosis. And in that setting, it sets one up for a predisposition for carcinoma. And so that was really what my graduate school training focused on. At the end of my graduate school training, though, and through the third and fourth year of medical school, I still stayed open-minded in terms of what specific field I wanted to focus my career on. And through these rotations, I actually came to decide I wasn't going to become an internal medicine physician and study liver disease and become a hepatologist, basically, which is what my lab PI is a hepatologist. In some ways, maybe he was a little surprised or disappointed that I didn't go that route. But for me, I was very focused at the time on getting kind of what I wanted out of residency, and also recognizing that I wanted to do research in dermatology and specifically work with dermatologists to investigate more all the different diseases in dermatology. And I don't know if you have a dermatologist who eventually presents with your program here, but they'll tell you that the number of different diagnoses in dermatology is in the thousands. There's so many. And a lot of the treatment options in dermatology are either give steroids or like take a biopsy. And so the number of treatment modalities, and this is overly simplified, of course, but the number of treatments in response to the different pathologies in dermatology seemed like a big black box, and it seemed like there was a lot of room to do research and also easy and quick access to patient samples. Like a biopsy from the skin is a lot less complicated and more commonly done than a biopsy from the liver, for example. And so for me, that seemed like an interesting way to go. And for many of the dermatology diagnoses, which I'll get more into in my subspecialty of dermatopathology, we actually don't know what causes them. And when you read a dermatology book, all these different names or diagnoses, oftentimes the etiology or the cause of the disease is unknown. And so this is basically a kind of a fertile ground for asking questions, right? And being creative about finding solutions for or investigating why these different diseases happen. And so just to jump into anatomic pathology, I decided anatomic pathology because it's really just 2 years of clinical studies compared to internal medicine or surgery, which is a minimum of like 3, 4, 5, 6 years. I was done with my residency clinical studies in 2 years. And then the third year, for residency, it's required to have 3 years of residency. But because I had a research track in anatomic pathology, I was able to use that third year to go back into the lab and do research in melanoma. And so for me, this is kind of the fast track, if you will, into my career. But before I get into dermatopathology specifically, I just want to point out that I am actually trained as a general anatomic pathologist as well. And so during residency and deciding to become a pathologist, the priorities that were important were to decide that I wanted to diagnose disease and that I wanted to contribute to patient care without necessarily interacting with patients. And I think this is an important branch point in residency, in picking a residency. If you're going to choose to become a radiologist or a pathologist, just to name two, those are two specialties that um, more often than not, you're not actually interacting directly with patients. There are a couple of subspecialties within each of those that you can choose to then further specialize in, like cytopathology is when you actually do interact with patients to some degree. And in radiology, there's interventional radiology where you actually do interact with patients. So it's not a hard and fast rule, but for the most part, people picking pathology are deciding that it's okay for them not to interact with patients. Like they're going to be okay with that. So asking yourself, what is a priority for you? And then if anyone is interested in pathology, of course, as I mentioned, pathology and research really do go strongly hand in hand. And so getting involved in research early is something that I also recommend for people who are interested in pathology. So again, pathology is really it's the branch of medicine that deals with laboratory examination of samples of the body tissue for diagnostic or forensic purposes. And we, on a weekly basis in our department, have a ground rounds that talks about, we discuss mechanisms of disease. So again, what is the underlying cause of the disease, and can we learn more about it through pathology? It's a very inquisitive and constantly expanding learning field for sure. Clinical pathology, so there's two branches. One is anatomic, which is the branch that I chose. The other branch is clinical pathology, and that's pathology having to do with everything liquid. So when somebody takes a blood sample or urine sample or cerebrospinal fluid sample, all those samples are going to go to clinical pathology. And in my hospital at UCSF, we actually consider those two different departments and two different chairs. So they're two different residencies, essentially. Some universities and medical centers will have clinical and anatomic combined, and some places choose to keep them separate because they really are dealing with different questions, different types of samples. And both my parents actually worked within clinical pathology and worked in the lab analyzing blood and collecting tissue or samples for culture. So microbiology is underneath the umbrella of clinical pathology. Whereas surgical pathology is underneath the branch of anatomic pathology. So anatomic pathology, which is what I did, I worked hand in hand with surgeons. So anytime there's a surgery, like shown here, they may take a little piece of tissue and they may open up the patient, look and see where the cancer is that they want to resect. And then oftentimes what part of our job is to check whether or not all the cancer has been successfully resected. So did the surgeon get it all out? And oftentimes the surgeon will send pieces of tissue from the margin, which is where the cancer was cut away from, and send it to anatomic pathology. And we will, on the spot, process the tissue in a matter of minutes. We freeze the piece of tissue, we cut a very, very thin section, and we put it on a slide and we look under the microscope. So this right here happens to be liver. This right here happens to be kidney. These are both normal, but what we would do is look for cancer cells. So did the surgeon successfully resect the whole cancer, or do we still see cancer cells at the margin? And then we would report back to the operating room. The patient still is open on the table. They're waiting for us for the answer, right? And we go back and we tell them what we saw under the microscope. And based on what we tell them, they will then make the decision to go back in and take more, make sure they have a clean margin, or we tell them, you're clear, it looks good, go ahead and continue the surgery. So that's what an anatomic pathologist does. They work hand in hand with surgeons or any outpatient procedure that involves a biopsy. Forensic pathology, I'll just mention because this is often the one that gets the most media, and a lot of times when I say I'm a pathologist, immediately the thought that comes to mind is, oh, so you're like CSI, you go to crime scenes and you do autopsies. And for certain, it is a rotation during my training, But then if one wants to continue doing that as a career, you would do a fellowship specifically in forensic pathology. And so the amount of training and exposure I have to forensic pathology, I think we can sum up in a 1 month experience, where I did have the option to go to the crime scenes. I did have the option to go and, I certainly participated in autopsies, and we discussed what are things that will come up, and what are things that we can learn from the different injuries that we see in people, et cetera. So forensics is its own thing. And I just wanted to clarify for anybody who thinks pathology is just forensics, forensics really is just a small piece of pathology. So what I ended up doing, my fellowship specifically, was dermatopathology. And I went into anatomic pathology residency knowing already I wanted to focus on derm path because, as I said, dermatology questions, research questions, were really what intrigued me the most. And so this fellowship I had to apply to the first year of my residency. So within the first 6 months, I had already applied because this fellowship is so competitive that they accept people 2 years before the actual start of the fellowship. And so being very clear and focused on my career trajectory and what I wanted to do was important. For better or for worse, is important for this fellowship. And it's only 1 year at Stanford, which is, I wanted to stay in the Bay Area. I still live in the Bay Area. And I went ahead and did that year at Stanford. And then the DermPath Fellowship is because it's so important to understand what the clinical picture looks like in trying to make a diagnosis from a biopsy sample. Pathology trained fellows will spend half of their time actually in a dermatology clinic. So you'll go in, you'll see patients, you'll learn about all the dermatology, different conditions, as much as you can in half a year, right? And then the other half of the time, I'm looking at slides and correlating what I see on the slide to the clinical images and trying to figure out what the diagnosis is. So I'm going to try to briefly go into an example. So dermatopathology. This is a dermatologist looking at a patient under a dermatoscope and seeing and deciding whether or not this thing needs to be biopsied. And so we take a little piece of that tissue, send it to me as a dermatopathologist, or does it look okay? And are we just going to follow it clinically? So that's the decision the dermatologist is making. Once the dermatologist decides to, so for example, this lesion right here, once they decide, I really do want to biopsy it because I'm not sure if it's just a mole, or another name for mole is a nevus. If it's just a mole and it's benign, or benign just means not malignant, or is it malignant or cancer, right? So that's the question. That's why they take a piece of tissue, send it to me, we process it, put it on a slide, and this is me actually at my microscope, and this is what it looks like under the microscope. So up here you have the skin on the surface, and then this is what we call the dermis underneath the epidermis, and down here this big blue kind of mass is the actual mole. And in this particular case, it is a mole and it's benign, but sometimes it's not super clear. And this is just normal skin histology. And this, just to show you, this is what normal looks like. Normally you wouldn't have this big proliferation of melanocytes. This is another example of a mole. So this is what I'm looking at kind of day in and day out when I'm on clinical service. Not just moles, but it happens to be my area of interest, so I use this as an example. I also look at skin for rashes, for other types of skin cancer like squamous cell carcinoma, but that's not enough time to go into all of it. So an example, so melanoma is my area of research interest now. And I just wanted to point out how melanoma these are all melanoma and they all look very different. And so one of the challenges in the research questions that was the most intriguing to me was, are there ways that we can improve how well we can diagnose melanomas, because they all look very different. And sometimes it's hard for a pathologist to decide if it's malignant or if it's just atypical or if it's truly totally benign and fine for the patient. So that's a very critical decision that we're making, and it has an important impact on patient care. So this is the process of making a diagnosis. So clinically, a dermatologist will look and examine these various features. So they'll look for asymmetry. Is the border irregular? Are there multiple colors? And that's a poor sign or poor predictor. And is the diameter greater than 6 millimeters? And evolution is the last criteria that a dermatologist will look for. Is it changing? Has it changed in size and color? And so these are the things that they look for clinically. And as a pathologist, I'm also looking at various things. So the things I look for, again, under the microscope, is it symmetric? Is one side the same as the other? Circumscription just means that it ends at the ends. You can kind of put a circle around it. And it's contained. Is, again, for me, the size also matters. So I have a cutoff of around 1 centimeter. If it's bigger than that, that's not a great feature. Maturation is just the size of the cells getting smaller at the base. And then I start looking for atypia. Hyperchromatic nuclei just means the nuclei are really, really dark. And then if I see any cells actually undergoing mitosis, so little mitotic figures in there, that can be a sign of each of these features don't necessarily mean malignant. It's me integrating all the features together and making a decision. So what is my overall impression? Is it benign, like totally fine? Is it kind of atypical? Am I a little bit uncomfortable? Is it maybe evolving? Or is it outright melanoma and malignant? So this is what I do for clinical. And I look at the clinical sometimes. I'm looking to see how concerned is the dermatologist, and then together with the histology, how concerned am I? All right, so just an example of a challenging case. For me, the kids always get me. So this is a 4-year-old child on the scalp. They had a melanocytic proliferation or pigmented lesion. And this is a separate kid. It just happens to also be 4, so I thought it was an interesting juxtaposition. This person had it on the chin, and this is what it looked like. So if anyone were to just show me these images, I would say, okay, well, this cell looks really large and hyperchromatic. That's kind of worrisome to me. But some of these other cells are kind of small. They don't look as worrisome. And here too, we have a couple of cells here this one looks a little bit funny to me. This one looks a little bit darker, a little larger. So, both of these had slightly worrisome features, and we weren't entirely clear. It wasn't entirely clear just based on looking at a slide. And so I put up here, sometimes histology is not enough to make the diagnosis. And in those cases, we use molecular tests. And this is something that is continuing to just rapidly evolve in pathology. Like, we're constantly coming up with new tests, new diagnostic methods, and just really the pace of science in pathology is really rapidly evolving. I think we can say the same for medicine in general, but as a pathologist, I'm seeing it firsthand quite a bit, especially when we're the ones making the diagnosis. We want to get it right. That is the goal. So fluorescence in situ hybridization, or FISH, is one way we can look at an individual nucleus. So this is a cell, this is the nucleus, and these are different fluorescent probes. And we know that at various chromosomes, if there is a loss or a gain in some of these chromosomes, that is actually indicative of the of genomic instability, or tumor suppressors or oncogenes being lost or gained. And so I'm not going to go into a whole lecture on cancer biology, but what this test tells us is, at a molecular level, are these cells not acting in a way that they should? So that's one piece of information, and it's only looking at a couple of different chromosomes. Another test I use quite a bit is comparative genomic hybridization. And this one gives you a view of all the chromosomes. So down here, you'll see chromosome 1 through X and Y chromosome. And so for each of these, we would expect these different probes. Each of these dots is a different probe looking at the entire genome. And whenever we have a loss of a chromosome, the line will go below 0, and we look for how low it goes. And if it's a gain in a chromosome, it'll go above. So you can kind of see, I don't know how clear it is on your end, but I'll just trace with my arrow. It's going down here. There's probably a loss, and then nothing, nothing, nothing. And then we have a loss in chromosome 9. And then we have nothing, nothing, and then we have a gain in chromosome 15 here. So this gives us an overall view of the genome. Again, just getting more information are the cells that we're looking at, are they altered in a way that is reflective of malignancy? And so going back to those 2 kids, we did a RayCGH, this last test I showed you on both of them. This one didn't have any chromosomal losses or gains, and we decided it was benign. And this one had several chromosomal losses and gains. So this was melanoma in a 4-year-old, which is, again, this is a big deal to give that diagnosis. So we want to be as certain as possible. So that's the end of the actual nuts and bolts of the talk, but I wanted to just end on a high note of why I love my job, if you can't tell. I do like the idea of making the most correct diagnosis possible. We don't always get it correct, but we do the best we can with the tools available to us today, right? And this really does play a very key role in patient care. So even though I'm not seeing patients face to face, I know that I'm making a difference, and that to me is really important. And really, dermatologists are my clients. I really enjoy working with dermatologists that, they see they see so many patients, they're taking so many biopsies, and there's a lot of actual conversation I have with them. So that I really enjoy. And they appreciate me. They turn to me for the answers, and we have this conversation, and it's just very satisfying. Another just very practical part of dermatopathology, I don't actually take call. I don't do general pathology anymore. I just do dermatopathology, although I can do all the others if I chose to. And then some dermatopathologists do take call. It's just you have the option of doing it or not. And then there's very few emergencies in derm path. So I would call it a somewhat low pressure job. And as a researcher, I do have direct access to tissue for projects. And so that's something I also really highly value. And I just continue to ask questions and help out with patient management in my own way. Advice for premeds. So I would just say, stay curious, engage faculty. You never know when there's going to be a mentor who knows somebody who can write you a letter of recommendation or even expose you to some interesting project or an area that you hadn't considered before. So that's always my first advice. Again, you're asking a researcher. I will give the advice to stay involved with research projects early. If you have no interest in research, please don't take this as a have to. We don't have to do any one of these things, right? And then of course, take advantage, going back to my original earlier years. I really did take every opportunity to volunteer or look for these sponsored opportunities that allowed me to do summer programs. And, at various interviews, when you are getting interviews for medical school, it's just really fun and nice to be able to talk about something unique, interesting, and kind of have yourself stand out from the crowd in a lot of ways. So those are some of my advice. And then I'll take any questions if anybody has questions.
If you guys have any questions, feel free to type it on the chat so I can read it out for Dr. Ling. I guess I could start with a question real quick. I was wondering, how was the transition for you from graduate school to medical school?
Yeah, that's an interesting question. It's one that I think all of my class were going back. We all commiserated a little bit of like how this was going to go. And it was, there was something to joining a medical school class that you didn't start with. So all the people I started medical school with graduated and moved on and became attendings, and I was still a medical student. And I was joining a class that for the most part was, maybe 4 years younger than I was, and perhaps didn't have a kid. So I feel like there was a little bit of I jumped ahead in terms of my kind of lived experience at the time. And that actually for me ended up being kind of nice. I wasn't as worried about being criticized or judged because I had plenty of that in graduate school, and I kind of, got used to defending what I was thinking or doing. And so in a lot of ways, the maturity I think that came from the PhD served me in third and fourth year. But at the same time, like some of the stuff that we learned in the first and second year had faded somewhat as happens, right?
Mhm.
And what at least Mount Sinai did was they had a refresher course for the MD PhDs coming back to medical school. So that was actually quite helpful, I thought. They do as the best they can to keep us at the same kind of level as our colleagues. But I was also to the point where I wasn't looking to get you know the perfect score, the perfect grades. It was more about let's um, get as much out of the experience as possible, and be curious and be there for the patient, and kind of drop some of the other drama that can come from being around a high pressure situation. So yeah.
Yeah, and also like how was your personal life balance with your school load? Because you said you had a kid during your graduate
Yeah.
school. So
No, that
that
was
sounds
actually, I think at the time I thought, well, in graduate school I have a lot of flexibility, so we might as well have a kid now than later. There's never a good time to have a kid. You're always going to be juggling at one time or another. And so, what I ended up doing is just the medical school had a daycare that was somewhat affiliated. I was able to get my son into daycare there, and actually, what I ended up doing, again, this is going back to just being creative and looking for solutions and kind of getting out of the victim mentality, like, that is never useful. So what I ended up doing is I made a Google Doc spreadsheet and I shared it with the class of medical students. And I said, hey, anybody want to babysit? Anyone want some babysitting money? I already knew that all the people that were going to sign up to babysit for me and help me out were CPR trained, had already gone through screening processes. And, I, for the most part, worked together with also a nanny, but in any extra hours I needed to go in, I had a huge support system, and medical students were more than happy to, take the the babysitting money. And of course, I was always about them coming, just come and study. For the most part, he's asleep for a lot of the time, and just kind of forming a community and finding the support system. It's out there. You just have to ask.
Mhm. So I have a question from Hamza. He says, what's a good way to network with a dermatologist as a student with no physicians in the family?
Mm. Again, this is about just making the ask. And I guess I wonder what are his thoughts about not just going out and asking for getting involved. And like it could be anything as simple as is there a case report I can work together with you on and write up? Faculty are always looking for people to help out with getting a publication out, and that's why I mentioned the research projects, because that's kind of an easy way to do it. The other approach, if you're not into writing and doing that sort of thing, would be to just ask if you can shadow. And if somebody says no, there's always the next person to ask. It's just about putting yourself out there, um, and sharing how you're very interested and want to get involved. And oftentimes you'll see that people will say yes, and that's been my experience for the most part. Just going out there, and it can be scary to ask people, but in the end of the day, like, that's really what it takes, is just going out there and making the ask.
Mhm. I have a very interesting question. It says, how much research experience would be enough for MD PhD? And the person is working towards his gap year, and due to financial responsibility, he's asking if it's disadvantages for older people who are like over 30 to apply for MD PhD?
No, I don't. I mean, how much research is kind of a hard question to answer. I would say of the people in my class, and this is again like so long ago now. How many years ago was it? It was like 10, at least 10, if not more. So like for me, I think that that research year between undergrad and medical school really helped me quite a bit. The fact that it was with NIH also, I think, helped me quite a bit. Um, but it also needs to be more than, I think in a lot of ways, it's like, what are you producing from that year? People can decide to do research years, but then not really have anything at the end of the year to show for it. So strategically, I would probably choose to do a gap or a research year with a goal in mind to have either be on a paper or have a paper, some sort of a completed project at the end of it. And that's just kind of that just adds to stuff you can put on your CV. So it's more of a strategy to leverage the research part. Because the MD PhD program is completely paid for, I feel like that also makes it competitive. And so it's almost like a numbers game. You know, the more projects you have, the more research experiences you can show, the better. So I can't give you an actual hard number of how much is enough. But I do know programs will look more to the research and less at the numbers, as in my experience. They're really looking for somebody who does show authentic passion in research more than what is your MCAT score. And my MCAT score was really average. And I think in part because the MD only programs really heavily, I mean, maybe they're trying to not do it as much. They're trying to look at more of a holistic approach to applications. But back, 15 years ago, whenever it was, like there are certain schools that just wouldn't offer me an interview because my MCAT score wasn't like in the top percentile, right? Um, and I ended up getting a lot more interviews for the the combined program because I had already a strong track record of being interested in research. So there's kind of pros and cons to like the research track. You kind of have to prove yourself before you get in that you actually will continue along. Because I also had at least out of the 8 MSDP class in my year, one of them joined the lab after the first year of medical school, joined his lab, and after the first month quit and decided he didn't want to do the PhD, got the first 2 years paid for, and then went back to the third and fourth year of medical school. So I think the programs are really looking to protect against something like that. Because the PhD, doing that on top of the MD, it's like, it's not easy, right? You're going to put in a lot of work, a lot of effort. There's going to be times when, I certainly went through a lot of ups and downs in my research projects. I spent 2 years working on a project that went nowhere. I had to start over again, and being okay with that, continuing to be passionate enough to say, I want to continue going. And I think that's kind of a quality that is looked for when you're looking at MD PhD programs. Is this person kind of interested in research? It's nice. It's or is this person really looking forward and what is their career and putting research in as a priority? So I don't know if that's helpful or just more stressful.
Yeah, that was very helpful. And you mentioned like your ups and downs during MD PhD. What are the things that help you like keep motivated throughout the journey, except for just your passion?
Well, I think passion, but also I think it's the way we think about how down is this really compared. And I always, like I mentioned, my mom, I've always been, and my dad also is an immigrant. They both really hustled, and I kind of saw the hustle and like what they did and the opportunity they gave me. In some ways, I kind of wonder if that also there's something to kind of question at the other end of it now. how much was I doing it for my parents, kind of? And I think first generation physicians and with their immigrant parents, they kind of have this, I need to take full advantage of the opportunities because my parents have worked so hard to help me have them. And so I think on the moments where things weren't working, I think I did very much use the thought, um, you know, as bad as this looks, it's not as bad as it could be as a comparison.
Mhm.
Um, and that's just, I think, my own internal dialogue. But aside from that, I think, having a close knit group of friends, and I definitely became very close. I'm still very close friends with my original MD PhD class. And we all kind of, just New York City is a big, exciting city, and we would spend some weekends out, and for every, play hard and work hard kind of was what we did. And recognizing it's a marathon, not a sprint. There's plenty of examples of when things didn't work out for me. And I thought, well, in the grand scheme of things, this isn't going to make a huge dent. It's just part of the process.
Mhm.
Yeah.
Thank you. Another question, it says, does the NIH offer clinical research opportunities where students could potentially get published?
That's an interesting question. I think that I can't say off the top of my head, but I do believe that there are more clinical research, like a clinical trial type experiences that could be something to consider if one was more interested in the later stages of research and not so much at bench work research. And yeah, I mean, I didn't look into that as much because I was very focused on the bench work. But interestingly, like my research now is very translational. I'm looking at how to improve diagnostic tests. So instead of pipetting in the lab a lot, I'm working with tissue and developing clinical assays in order to help to increase our diagnostic capability. So never know where where things will lead you. And I have like I probably have now 8 or 9 different mentees that work on various research projects with me. I love mentoring, and and I'm always very excited when I have residents or even medical students come to me with some enthusiasm. That's always very welcome. So I feel like not everyone's like me. Not everyone will say yes, but there are people like me out there who are more than welcoming to involve somebody at whatever level they want to be involved at. Yeah.
And one last question, is dermatophathology just exclusive for MD PhD students?
No, not at all. You can. Um, there aren't. Yeah, I don't actually know. I maybe know one other person who's that's not true. Maybe a couple who are MD PhDs in dermatopathology, but for the most part, they're MDs. And you can actually do derm path through the derm route or through the path route. So if you're a dermatologist and want to also sign out derm path cases, you can also do that year of fellowship. And at the end of the year, you can basically, you're qualified to do read out pathology cases just for dermatology, right?
Mhm.
And that's unique in that kind of, that's the only fellowship in pathology where like an outside specialist can come in and also do the fellowship. So my
Um,
co-fellow at Stanford was a dermatologist, for example, and she had a different perspective and I had the pathologist perspective, so we helped each other out quite a bit.
mhm. It's really interesting. I'm just gonna wait for more questions. If people have any more questions, feel free to type it in the chat. Yep, I feel like that was all for the questions. Thank you, doctor, for being with us today. Like, I
Yeah.
know your time is very valuable. Thank you for joining us. We're very grateful. And as a first generation student myself, it's really inspired to hear your story from your journey from
Totally. So
medical
good.
school,
So
like
good to hear
graduate
that.
school. Yeah.
It was a pleasure to be here, and I hope you know, everybody out there can just keep going, find something that you know that you love, and reach out for people's help. I think we all help each other, and we're more than happy. That actually leads me to, I wanted to end on the you know, if you do want to follow me on Instagram or Twitter, I'm also a coach now. I found that coaching was very helpful to me, and kind of when you asked me the question about the ups and downs, I now do a lot of mindset work, and I think that's a skill that you can develop, and I do that now. And I do have my specific niche is physician scientist coaching, but I'm always happy to answer questions and direct anybody to coaches who are interested in more general coaching too. So that is all I have. Thank you.
Yeah, thank you for sharing your information. That's really helpful. Sure.
Okay.
Yeah, and for those who are attending right now, if you wish to take the assessment, we have posted the Google form link in the chat. We'll have 45 minutes to complete the form after the session, and you'll have to pass with a minimum of 7 out of 10 points. And please try to use one email throughout all the sessions so that it's easy to track your hours as you continue to participate in our program. We will be providing certificates by the end of May with your total hours for spring. And our next meeting is happening tomorrow, February 24th, with Dr. Ami Shah. She's a physician in ophthalmology. And again, thank you all for joining in.